It's Tuesday, November 19th, and this is the Daily Medical News, where we bring you the top headlines in clinical medicine, plus a closer look at today's biggest story. I'm Molly Collegio.
And I'm Nick Andrews. Today, the feds are floating new rules to make healthcare pricing more transparent.
Most charity assistant programs don't cover uninsured patients' prescriptions.
There's more evidence a diabetes drug cuts mortality in heart failure patients without diabetes.
And how to conduct effective suicide screening in pediatric medical settings.
Plus, why the ISCHEMIA trial could change the way you manage patients with stable heart disease. But first, thank you to all of you who have helped us make this podcast better by taking our short listener survey. If you haven't, please take a moment to complete the survey by following a link in the show notes. We would greatly appreciate it, and the survey is, of course, anonymous. And now, the top stories in clinical medicine.
Most employer-based health plans and health insurers would have to disclose price and cost-sharing information up front if a new federal proposal becomes a rule. 3 federal agencies jointly released the proposed Transparency in Coverage Rule. The goal: give consumers accurate estimates about the out-of-pocket costs for medical services, and thereby encourage them to shop around for medical treatment. Most group health plans and health insurance issuers would be required to give their members real-time estimates of cost-sharing liability for all covered items and services. Health plans would also have to publicly disclose their negotiated rates for in-network providers. And they'd have to share publicly the allowed amounts paid for out-of-network providers. The proposed rule is now open to public comments for 60 days.
Almost all of the patient assistance programs run by independent charities to subsidize prescription drugs exclude uninsured patients. That's the primary finding from an analysis of nearly 300 patient assistance programs run by 6 independent charities, 97% of which listed insurance coverage as an eligibility requirement for their program. Researchers at Johns Hopkins University in Baltimore warn that their findings suggest some features of the programs might limit their value for financially needy patients, and other features could bolster the use of expensive drugs. In 2017, the 6 charities spent an average of 86% of their revenue on patient expenditures. The researchers also found that brand name prescriptions were covered by an average of 3 assistance programs compared with an average of 1 program that covered a generic version of each drug. And prescription drugs that were covered were more likely to be expensive compared with drugs that weren't covered. These data appear in JAMA.
The practice-changing DAPA-HF trial gave strong evidence that the diabetes drug Dapagliflozin cut cardiovascular death and acute exacerbations in patients with heart failure with reduced ejection fraction, even among those without type 2 diabetes. But a new analysis of the 55% of the trial's patients who didn't have diabetes should seal the deal. Dr. John McMurray says the relative and absolute reductions in cardiovascular death and hospitalizations or urgent visits for heart failure were substantial and clinically important. And those benefits were consistent in patients with or without type 2 diabetes. Speaking at the American Heart Association scientific sessions, Dr. McMurray of the University of Glasgow outlined the primary findings from the patients without diabetes. In short, those with a normal hemoglobin A1C level at or below 5.6% had a 26% relative reduction in the study's primary endpoint. That's essentially the same response as the 28% relative reduction in events in patients with type 2 diabetes. We'll be back after this message with more medical news.
Welcome back to the Daily Medical News. I am Nick Andrews. Given the rising rates of adolescent suicide, screening to identify at-risk patients is particularly important. and that screening can take as little as 20 seconds. That's the advice of Dr. Lisa Horowitz, a staff scientist and clinical psychologist at the National Institute of Mental Health in Bethesda, Maryland. But Dr. Horowitz cautions that clinicians need to use validated screening instruments that are both population-specific and site-specific, and they need practice guidelines to treat patients who screen positive. Many practitioners identify suicide risk by using depression screens, such as the Patient Health Questionnaire for Adolescents' Questioning Number 9, which covers suicide ideation and self-harm. But preliminary data suggest those screens often are inadequate. And Dr. Horowitz says just one question, especially one without precise language, won't identify as many at-risk youths as more direct questions about suicidal thoughts and behaviors. Consider instead a clinical pathway developed by the Pathways to Clinical Care Suicide Risk Screening Work Group. It begins with the Ask Suicide Screening questions, which take about 20 seconds. Those questions were specifically developed for pediatric patients in the emergency department, and they've been validated in both inpatient and outpatient settings. For more of Dr. Horowitz's screening suggestions, click the link in the podcast notes.
The ISCHEMIA trial compared invasive versus conservative management for patients with stable ischemic heart disease. And the response to its findings at the American Heart Association scientific sessions was emphatic. Ischemia is practice-changing. Ischemia included more than 5,000 patients with moderate or severe ischemia. It showed that an initial invasive strategy plus optimal medical therapy didn't top optimal medical therapy alone at reducing the risk of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. The composite endpoint rates at 4 years were 15% with the conservative strategy and 13% with the invasive strategy. Nor was there a significant difference in the major secondary endpoint of cardiovascular death or MI, 14% with the conservative strategy and 12% with invasive management. And to the investigator's surprise, patients with more severe ischemia or more extensive multivessel involvement didn't do better with the invasive approach. In patients who had angina at least once a month, an invasive strategy did deliver significantly better angina control and quality of life than optimal medical therapy. But an invasive approach gave no quality of life advantage in patients who reported no angina within the past month at baseline. Dr. Alice Jacobs is director of the Cardiac Catheterization Lab and Interventional Cardiology at Boston Medical Center. Given the findings, Dr. Jacobs says she'd feel comfortable advising patients without angina or with controlled or tolerated angina not to undergo an invasive strategy. And that's it for today's Daily Medical News. If you like what you're hearing on the Daily Medical News, leave us a rating or a review on Apple Podcasts. For MD Edge, I'm Molly Collegio.
And I'm Nick Andrews. Thanks for listening. We'll be back tomorrow.